Hi, my name is Peter. I'm a specialist in emergency medicine from Denmark, working in Stockholm, and um, I wanted to do a quick and dirty lecture on a topic that I couldn't find much knowledge on when I was looking at both at foam and also like in general guidelines wise. Um, and I'm particularly interested in this topic as I'm doing the marathon shift, meaning that during the upcoming Stockholm Marathon, I will be on duty and I will be one of the leading doctors there. So I had a vested interest, or still have. I have a vested interest in um, digging a bit deep in this topic and how I have to manage this shift, and also how we all manages these sports events that are getting more and more frequent. And with our hotter weather, this seemed like a very relevant topic to talk about. So I'll be going through, as I said, quick and dirty, exertional heat illness for emergency medicine. As always, firstly, I want to show you the references. And this is not an extensive review I've done of the literature, but I've scattered I've checked FOAMED, some of the best sources I know, and there might be missing some resources here, but a lot of the resources that I'm missing are overlapping or referencing to each other. For instance, life in the fast lanes, heat stroke, I didn't bring that in because it's covered in the other references here. I will highlight that there are a few studies or expert consensus statements from different organizations that I'm relying heavily on here, and one of them is Roberts from the ACSM. I cannot remember the acronyms here, but these are sports medicine societies in America. Who made this, and they made this consensus statement in 2023. And I'm also relying a bit on this Belval 2018 consensus statement of pre-hospital care for exertional heat stroke. And there are a lot of videos on this particular society's homepage on YouTube, where they have a lot of videos on this topic, amongst other. Otherwise, it's mostly foam. And some guidelines or semi-guidelines from different societies, ARCAM and EMRA, which is the English and the the British and the American Young Society, and then a little bit about complications for heat illnesses. We'll go into that, but references for that is here. Okay, so first of all, terminology and definitions. And this had me confused in the beginning because, or somewhat still have, because there's not an agreed upon definition, as I understand it, of some of the conditions or some of the sub-conditions here. And a lot of it is clinically defined. So I'll go through what I found and I'll show you. All right, so in general, we're talking about what we call heat or exertional heat illnesses, and then the complications for those exertional heat illnesses. So the mildest, quote unquote, mildest level of this is what you call EHE, or exertional heat exhaustion. We have a athlete collapsing, but they will not have any organ damage if you were to take blood samples on them, or they might have some, but very mild, maybe electrolyte disturbances and so on. They may have a temperature, but it's almost always below 40 degrees from the beginning. And it's important in this definition that they do not have any neurosymptoms, meaning that they're not confused, obtunded, seizing, or anything like that. These patients pre-hospital is the majority. These are the main patients that you need to pick up really quickly if they do have some of the symptoms that I'll show you later as well. And if they do exhibit these, you have to cool them really fast within 20 to 30 minutes. And it's aggressive cooling from the beginning. And then they might or might not get some oral fluids or salts, depending on what what their problem is. And if they do not improve, then they will have to be taken to the hospital. And here's what the NICE guidelines also say, or the NHS guidelines says for patients. Like, heat exhaustion does not usually need emergency medical help if you can cool down within 30 minutes. And if it stays at this level, they do not need to have any prolonged recovery time to be able to play sports afterwards, maybe 1 or 2 days. But as I will not go too much into details about prevention here, but in general, there's lots of literature talking about how if you are working out in warm environments, you need to acclimatize by doing stepwise incremental steps in the heat to be able to adapt to the heat. If you just go out in the desert and try to run a marathon, you will die most likely. So you need to have some adaptation techniques, and it has to be built into any kind of athletic programming in warm areas of the world. All right. And then you have, in the other end of the spectrum, you have what you call EHS, or exertional heat stroke. And this is what we really are afraid of. This is where the thermostat of the brain is turned off, where you get, when you get body temperature usually of above 40 degrees. But importantly, this is not a rule out. Usually pre-hospitally, they will have cooled the patient so that when the patient arrives at our doorstep in the emergency department, they might be colder than the above 40 degrees that is often mentioned in the literature. And this is what the neuro literature also says, like, we cannot rely on this solely. What is a hallmark symptom of these patients is that they have end organ damage, and the most distinctive end organ damage is the neurological symptoms, which range from mild personality changes to unconsciousness and seizures as well. And I've seen a couple of these when I've had the marathon shift in other years, and they definitely do cease, and they are obtunded. So you can quite easily know these two groups apart. Then the Arkham says like this. Oh, sorry. They're also disorientated, and they usually will. This is not a sure sign either, but they oftentimes will not be sweating because their body is not compensating anymore for the heat. The clinical findings might vary, right? So, but what the Arkham says that sweating has been reported in cases of heat stroke, and core temperature may have fallen below 40 degrees, exactly as I said. The key distinguishing factor is that these exhibit an inflammatory response, right? Heat stroke is heat illness associated with a systemic inflammation response, leading to multi-organ problems in which encephalopathy predominates. The presence of neurological problems and hot and dry skin distinguishes heat stroke from heat exhaustion. Exactly. So that's the clinical distinguishing feature between these two. And as we'll talk about later, cooling is aggressive cooling with all of these patients is like, if you only take one thing away from this, it is that as soon as they exhibit symptoms, cool them for the love of God, as fast as possible, so that an EHE will not progress further. All right. So, and a thing about these, once you have developed this is a systemic problem in your body, and you will have to return to sports gradually. And there's great guidelines for that. It may not be too evidence-based, but there are definitely guidelines on it. ACSM on the references, you can check that out and see where they in detail describe how to go back. And this is a program spanning weeks before you can go back to normal level. All right, this is where for an emergency physician becomes complicated, because all right, so far these usually are treated pre-hospitally. They don't need to come in. These are always coming in because they're in a bad way. They have neurological symptoms. Then you have this in between definition thing, which is called a little bit problematic as well, EHI, which is also exertional heat illness acronym, but this means exertional heat injury. And this is, as I understand it, as EHS, as the heat stroke, but without the CNS injury. But they might have, they will have blood sample injuries, or like they will have a bump maybe in the liver problems and so on. So this is what the ACSM guideline says. EHI is characterized by evidence of organ damage, i.e. gastrointestinal, kidney, liver, and muscle. So muscle would be creatinine, myoglobin or creatinine kinase. Kidney would be creatinine, and so on and so forth. And dysfunction in the presence of hypothermia without CNS changes seen in EHS, and requires laboratory testing to establish the diagnosis. So there's this middle ground here as well. And what is frustrating for me as an emergency provider is, who do I actually take blood samples on, and which blood samples will I take? Because I do know also that there are several studies that show that the patients coming getting all the way to the goal line in a marathon run, for instance, they will have a bump in their troponin, they will have a bump in their CK, and so on and so forth. So where does the line go here? And maybe is it like, well, all marathon runners, whether they collapsed or not, do have some degree of organ injury that might just resolve by itself? I mean, this is a problem when you happen to be in the emergency department, right? Because now we do take the blood samples, and then we have to decide: is this a patient that has to take serial blood samples or not? And where do like, because of the lack of guidelines on this area, we are kind of doing everything just by what we think, because we cannot admit all the marathon runners coming in, right? But on the other hand, I don't want to miss anything serious, right? So here's a problem. That's partly why I made this lecture, to try to find out how to do this. And like, spoiler alert, I didn't find a great answer, but I have found out that because the literature is like this, then probably we just have to find out by ourselves, case by case. All right, and then we just and the ACSM talks about, they are not quite sure whether this is a spectrum, like where this is milder or this is more severe. It probably, there is some components of that, but they might think that it's not necessarily totally linear. This you might get into this right away and jump over all the others. So please read the ACSM paper for details here. Then the complications, and I just mentioned a few, but some of them are rhabdomyolysis and EAH, which we will be talking about. The DIC and liver injury, I will not go into details with. All right. So the common signs of symptoms of exertional heat illness are posted here. This is also from the ACSM. You can pause and check them out, but there's a slide a few slides away that will show an algorithm highlighting these. But in general, is you find dizziness, headache, nausea, unsteady walk, so on and so forth. I mean, like if you're out for a run, you might find that you have headache, you might be a little bit dizzy, and so on and so forth. But then like if you become, and tachycardia, hopefully most of it have that. But some of the signs, like missing assigned tasks and being like fatigued beyond what you usually would be. I mean, I understand why this is hard to pick up, because these are also with a high overlap of like doing sports. But yeah. Then you have signs and symptoms of suggesting exertional heat stroke, though, and that is especially the CNS symptoms, right? Delirium, inappropriate behavior, aggressiveness, and so on. Ataxia is an early sign as well. You cannot ambulate, and then you might have incontinence, and then recurrent vomiting, and also high rectal temperatures. And we'll come back to that, but rectal is key here. All right, so let's go through some of the algorithms from these guidelines. And what is emphasized here is once the patient gets to the hospital, then the main thing is actually over. The main, the main takeaway here is that pre-hospitally they have to be cooled aggressively and effectively within the first 10, 20 minutes, maximally 30 minutes. And they think of the process like the chain of survival sort of in these patients, kind of like the chain of survival in cardiac arrest. So rapid recognition, rapid assessment, rapid cooling, and then rapid advanced care if needed, right? So this is from the NUM block, where they kind of, like I did, but took the literature and tried to make sense of it. So when they have if you have a patient that is collapsed pre-hospitally, then you first of all you want to assess, do they have a pulse? Is this a cardiac arrest? And then you go into a cardiac arrest algorithm. Okay, so it's not are they breathing and do they have a pulse? All right. If they do have a pulse and they are breathing, then you will have to find out, are they obtunded or not? These are, if they are AP stable, then the problem is here, are they destable? So if they have a normal mental status, then it could be a collapse in exercise, meaning that you could have a trauma, right? You could have fallen and hit something, and with various degrees of severity, especially if you're an older osteoporotic marathon runner, then that's definitely something that you have to think about. It could be cardiac, right? You could have, let's say, you could oftentimes when you have these major events in cities, you maybe have 30 or 40 or 60 or maybe 100,000 sometimes people running, and like just by sheer chance, 1 in 100,000 may have a Brugada symptom or a Brugada pattern that they didn't know about, and then they collapse and then they feel fine afterwards. But the heat and the exertion might just be that teases out that, or they might have an HOCM, or they might have some kind of inborn arrhythmia they didn't know about. So think about in the collapsed patient whether they might have this as well. Anaphylaxis, well, if you were stung by a bee, maybe, or something like that. I'm not sure whether that is, but that is something that should be on the radar of everyone when someone is feeling really or doing really bad. And then the heat exhaustion that is the topic of the day. And then we'll treat illness specifically, and then but if they collapse post exercise, like after the exercise, then it might just be exhaustion. But I would say some of these things do still apply. If they might have made it to the goal after the trauma, then the epidural bleed really began to press on the brain. Then that might be so. Think about all of these things. Even I wouldn't cut the border where it's post or pre in exercise. Also keep in mind, exercise collapse, sudden collapse without any prodrome is a red flag in the European guidelines from 2018-19 on syncope. That is actually an admission in their guidelines. So it's a high risk feature, and it's worth an admission. So that's worth thinking about. All right, and then if you have abnormal mental status, this is where you have to think about all of these things. This is where we in the emergency department had to think. So could there be seizing? Could there be some toxicology, like maybe doping or so on? Heat exhaustion and so on here. Could they be hypoglycemic? In that case, give them sugar, of course. Exertional heat stroke. We'll talk about that. That's rapid cooling. Actually, that's also for the heat exhaustion, but maybe less aggressive. Hyponatremia. We'll talk about EAH, exertional abnormal hyponatremia, and then hypothermia. And hypothermia, you could be cold as well, right? You don't have to be warm, depending on where you work out. right? So these are some, I think, excellent things that to broaden our way of thinking about these patients. Um, and several of these things might happen, be overlapping. Patients may be ceasing, having low glucose, having heat stroke, and hyponatremia, right? So they might have multiple things. This is the pre-hospital guideline from the ACSM from 2023. So first of all, I just want to highlight suspected heat illness. If you have a suspected heat illness, these are the symptoms: unable to walk, missed assignment or tasks, mental. They think highly of the neurological symptoms because I guess they are really specific. Of course, if you have seizures, unresponsive to voice or pain, loss of bowel control. Um, so this is so if you have suspected heat illness, move to the shade, remove all clothing, or excess clothing at least. Do vital signs and rectal temperature again. Rectal is really important. Assess mental status and call paramedics. And then you go into these two broad categories. Either you are weak but you are alert. You might be vomiting and so on. That's all right. That's probably just like quote unquote just heat exhaustion. Then you have to begin cooling, and cooling could be like uh, we'll go into the details of how to cool, but this is maybe not submersion in water, but it could be like the main thing with cooling is getting as much body surface area as possible involved or engaged in cooling. So taking off clothes, um, having water poured on you, and optimally being submerged in water, right? Um, and then rest so that you don't exert yourself anymore. Remove clothing and elevate legs so that your blood pressure comes back, and oral fluids, and importantly, the fluids have to be with some electrolytes. It could be bouillon, it could be with like pickled stuff with high salt contents and so on. And then reevaluate after 10 to 20 minutes. And these things should make them better, or they have to be in a trajectory where they are becoming better. If not, then they usually have to be admitted or at least seen in hospital. All right. Then, on the other hand, going the other way, you have someone who has a temperature, usually a rectal temperature. And this is pre-hospital, right? So here they will probably have a rectal temperature of over 40. It's just in hospital you cannot make the distinguishing between heat stroke and or not heat stroke because they might have been cool pre-hospital. But here it's pre-hospital when it happens, and then oftentimes they will have a temperature over 40, meaning that the um, as we know with other hyperthermic patients, such as the hot and altered patients, that as we talked about in other lectures, these patients will like once you get over 40, maybe 41, then oftentimes it's more likely to be hyperthermia than actually a fever, and it's a different mechanism, and it's here you need active cooling. Paracetamol and such will not help. So that's probably heat stroke. Then means begin aggressive cooling measures and cool first and then transfer second. That's an important mantra, because if you don't cool them within the first 10 or 20 minutes, then they will have high risk of complications. And then transport to the facilities once they are below 38.5. All right. Again, so there's a few key takeaway points here. One of them is you attempt cooling, like aggressive cooling from the get-go. This has to be planned. So you need to have a plan if you have a big marathon or a big event and it's 35 degrees Celsius outside, especially if it's novices like sport runners for fun or stuff like that. And if they haven't run for a lot of like big public events, are usually a few professionals, but a lot of like amateurs. And if amateurs are running, then there is a high risk of these things in the heat. So yeah, take homes here is cool first, transport second. You can transport them once they have a temperature of maybe below 38.5. or even better, if they were obtunded neurologically, then only transport them once they are cooled enough so that they are either below this or not obtunded anymore. There is no such thing as cooling too quickly. You can only cool them. There's like cooling them too quickly is just amazing. Just submerge them in ice if you have it, but most places don't have it, so they will submerge people in bathtubs or kiddie pools, or if you have you can buy stuff like you can buy a presenning or like a something that can keep in water, like and then you can wrap the patient in that, and like almost like a body bag, and then you can like pour water into that. That's also a submersion. That's great. That's also a great technique. These things require planning. CVI, which is I don't remember their acronym, but this is exactly what I'm talking about. Submersion. If you need to have like a lot of kiddie pools or like to submerge people, and then you have to plan it, right? You need water, and you need like transport patients from the area where they collapse to the. This takes planning, right? So if for big events, they need planning, and then. As I said, the first 10 or 30 minutes are gold. The experts in this field usually say like, I don't know how evidence-based it is, but the mortality is 0% if you can cool them quickly. If you cannot cool them quickly, then the mortality will rise, and the risk of complications will rise. And I think heat stroke, if they develop the fulminant heat stroke with organ damage, then they will have a mortality rate of maybe 30%, something like that, depending on the studies. So it's really like, again, take home, cool aggressively. Okay. And this is just another guideline. This is from the Bilbao. Bilbao. It is with a V. And again, patient collapsed during or after physical activity in warm weather. Well, assess responsiveness. If they do not respond, then of course you have to go into a cardiac arrest algorithm. If they do respond, assess CNS function. If it's normal, then you provide what they call palliative care, which is an interesting word choice. Like I guess it's technically true, but it is a bit pessimistic to call it that here. But what they mean is supportive care, I would say, where you try to remove them from the shade and so on. Then if it's disturbed, then you will have to assess the vital signs, and then they will. I think they've moved beyond this. Actually, they will just go no matter what the temperature is. I think if they're obtunded, then they should probably be submerged right away, like whole body cooling in some way, right? And then once you have cooled them, and this is essential, cool first, transport later, then you move them to the hospital. But only, and in this guideline they will say 38.5 or 38.6 degrees Celsius. Below that, then they can be transported. Okay, moving to where we are and where I'll be again during the marathon shift. So once the patient comes to you, what is important, I guess, just a few things. Lots of you do your normal assessment. It could be anything when they're coming in, as we said, everything, especially what you highlight the cardiac history, you highlight the exertional history, right? And one of the things that you want to know from the ambulance is, have the patient been altered or have CNS symptoms pre-hospitally, because you don't know necessarily. And what's the temperature rectally over 4 degrees Celsius? And that they might not know. Here in Stockholm, they don't have rectal thermometers. So you do a Mabel's, and you do the age, and you want to do you do a risk assessment for cardiology and or kidney and all the other things as well. But these are some of the things that are important to pick up before the ambulance leaves. The thing about rectal temperature, you actually we don't have it in Stockholm, sadly, but this is the ideal thing, and they have done studies on this, that other methods are unreliable. And this is what the ACSM says. Other common body temperature measurement sites, such as the oral canal, which is what we do in Stockholm, oral, sublingual, temporal artery or forehead, and axilla, are inaccurate estimates of core temperature and should not be used for clinical decision making to assess heat-related problems. So what I'm stuck with is, I mean, if any patient has above maybe 39, then I will have to put in a central thermometer, like meaning a catheter or a rectal or something like that, or 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 oral into their esophagus, like any of these core temperature measurement devices. And that's a bit aggressive for a lot of the patients, especially if they're neurological intact. And I think my measurement would just be active cooling, aggressive cooling, and then measure again to most of them. Once because I don't have a rectal thermometer. Then an ECG I think is sensible, especially for like you don't know why they collapsed. And then a lot of these studies, this is one of my things here, like EHE, the heat exhaustion, they often just stay in like at the site. They don't come to hospital. So there is a certain triage that has been done by the people at the site, meaning that the people who does come to us in the emergency department hopefully have been taken good care of pre-hospitally with cooling, and they've tried different stuff, and these patients are selected. So these patients they are worried about for some reason, for any reason. They might have a history of something. They might be older, or they might be they might not recover quite as fast as they wanted within these 10 or 20 minutes, even though they might be doing fine. Like these are the patients that we. So this is actually like this is where I'm relying on people's own experience and the pre-hospital care to triage these people for me, because I don't think we should avoid doing blood samples. There's no literature on this. I have not found any literature on who to take blood samples on. So once they're in the hospital, I do need to assess these, because these are not everyone just feeling fine after a collapse. These are the patients that they have been selected. So my takeaway here is I probably need to take the full blood sample set on most of these patients to be able to assess their risk. And what annoys me is that a lot of these tests I have to do them. I might have to do them serially, meaning that they have long wait times in the emergency department. For instance, for assessing rhabdomyolysis, because these blood samples only increase after a couple of hours, or like 2 to 12 hours, as we'll get into. So this is not uncomplicated. And if you have a lot of patients coming in besides your usual flow, then this can become a huge undertaking to take all of these blood samples and serial blood samples on these patients. If it was just once, then it's all right. So you can err on the side of conservatism, like saying like, okay, I only take some of the blood samples of the patients that come in because they're doing fine. But I don't like none of the studies, the reviews, the expert commentaries I've seen recommend this. They don't not like and they don't like advise at all. So they say these are the blossoms that are sensible, but it seems they kind of say like, oh, every hospital has to have a local protocol, and they think that you should go there. So you have to have a local protocol for these things. Meaning that, yeah, our hospital I don't think has one. And I have tried to search for other hospitals protocols, and I can't seem to find any. So this is again, this is an area that is kind of getting us into an area as physicians where we're kind of like, okay, should we just have to go with our guts here, and that's okay. But if we get it wrong, who will support us then? Okay. I do think, though, that a lot of organizers are doing this, and I do think that most of the patients probably will be quite easy to, in my previous experience, they've been quite easy to get home from the ED if they're talking and doing fine, and they might have a little bit of organ damage, but it's not a lot, and then they can go home. But if you do the American way, then you have to admit anyone with any kind of organ damage, right? And we don't have the space for that, so we are in a kind of a dilemma here. Okay, and then just remember, so what I think is good baseline tests are like you do infectious counts, maybe liver functioning tests, because that's like pick up liver failure, creatinine, and blood gas to pick up the electrolytes, glucose, and the pH. And then this is where I don't really know. Maybe not do Rhabdo tests for all, and maybe not do DIC tests for all. And then you can do, and then you should do all other relevant blood samples depending on what kind of conditions you're suspecting. If you do have ACS symptoms, then you should definitely do an ACS workup. But as I said earlier, most people will have troponin bumps, especially high sensitivity troponin bumps after a marathon. If I remember correctly from the literature. So just be aware of where the baseline is for the average marathon runner on these blood samples, because that would be a huge help to actually have those data. All right. Here's just this is also from the ACSM. This is also what they like. Some of the following laboratory tests may be needed to assess clinical status and guide management. So they don't really want to say what to do. They just tell us this could be. And they also say in the text, like, organ and tissue damage may not be detected initially, and serial clinical testing is required to measure the extent of tissue damage. So again, we're not getting a lot of help here in this area for these. Yeah. So what is the management once they arrive at your door? Well, I guess the dichotomy of are they warm or are they not is the most important distinguishing feature. If they're warm, then they need to be actively cooled, right? And that's what we talked about, like aggressive cooling and time to cooling is essential for slowing down the pathological process and reducing mortality. And that's really this is really an emergency, but it's mostly pre-hospitally it's an emergency. So, but if they have forgotten to cool the patient, or if they don't know about this evidence pre-hospitally, then you have to cool them, right? But we don't when we are in a problem in the hospital, because usually they are better equipped pre-hospitally to actually cool the patients at these events, because they have organized so that they have planned for this and how to do it. And we somewhat have, but we don't necessarily have we don't have the bathtubs. I know some places in New York with the hypothermic patients, they will do body bags. They put them in body bags and then they'll pour in water. That is one way of doing it. What we do is that we put cold towels in the axilla and the groin, and then maybe not put over a wet blanket on them, and then have a fan blowing at them, and then you have to you can't just do this once. You have to renew the towels sort of once they get warm. This is the fact that they often state, the experts in this field, this is 100% survivable condition if they're cooled fast, and this usually pre-hospitally. And then they say, then they go into the science of it. While a minimum cooling rate for achieving favorable clinical outcomes has not been established, cooling rates above 0.08 degrees per minute appear to be acceptable, and cooling rates of above 0.15 degrees per minute are desirable to reduce both morbidity and mortality. And insufficient and delayed cooling may result in clinical outcomes that include prolonged hospitalization and even death. And then the question is, when do we stop? So, and you can read this for yourself as well. But in short terms, it's cool them until they're shivering. And the thing is, they argue a bit back and forth whether you should take a rectal temperature on them. Like if you have a monitor device where you can monitor them continuously, then it's easy. Then it's easier. Then you might like go to 37 degrees or something like that. But if you don't, then they don't want you to check frequently. They just want, because they will delay the cooling. You'll just have to cool them until they're feeling better, all right? Until they're waking up, or until they are until they're not warm anymore, and they should be like neurological intact, or at least near that. Checking, yeah, exactly. So when an indwelling thermometer is not available, repeatedly measuring rectal temperature interrupts body cooling and reduces the overall cooling rate. Simply continuing uninterrupted cooling until the victim clinically demonstrates a return to normal CNS function, i.e. wakes up with open eyes, normal behavior and conversation, heart rate and blood pressure, may be a more effective cooling strategy. In this clinical scenario, checking a rectal temperature when brain function and vital signs have returned to normal will confirm the active cooling can be stopped. And if the victim does not show signs of clinical improvement, waking up in 30 to 40 minutes, clinical reassessment is indicated. Then you need to think about something else, or whether your cooling strategy is effective enough, right? The recommendation to stop cooling at 38 degrees, because a lot of the guidelines says this, to prevent hypothermia, is not based on data showing adverse clinical outcomes. Most overcooled heat stroke patient casualties are in 35 or 36 rectal temperature range, which is in normal body range and is associated with, not associated with any known harm. So they would say aggressive cooling, you cannot cool too fast, and if you overcool, that's not a problem, right? Then you will give them IV fluids oftentimes. If it's EHS, like heat stroke, then you will give them IV. If it's EHE, exertion, then it's oral. So if they're obtunded, of course, IV. If they're not, then if they don't vomit, then you can get oral. Maybe they get one IV and then they can get oral after that. But consider not overhydrating them. This is also what the guidelines say. You have to hydrate them. Just don't go overboard with it. Don't do like pre-2010 sepsis management. Then, all right, so and then you have to consider, when you're doing your fluid plans, right? You have to consider the hyponatremia and the exertional rhabdomyolysis. We'll talk about that later. And then, if the patient are drinking orally, then they should be having some kind of like something that is containing salts, right? So bouillon or high salts fluids, and it's important here that sports drinks that you can buy are not. They are hypotonic. They're low tonicity, so they're not iso or hypertonic as we would like here. And this is also from the ACSM. Oral fluid ingestion is preferred to IV fluid replacement and should be started when the patient can tolerate oral intake. The risk of vigorous IV fluid administration in the field include dilution, hyponatremia, and fluid overload. This is in the field, though, but which can inadvertently increase morbidity and mortality. And then you have to talk about management, about return to sports, and then you have to see the details in ACSM. But if it's EHE, return to sports should be uncomplicated. If it's EHS, takes weeks. And if it's EHI, we don't know. But they have to be followed up probably with the blood samples. Prevention, also, we talked about how to prevent it another time. Good advice at how to do sports in the sun, and so on and so forth. This is just an overview of the different cooling methods and how effective they are. And remember, here was what is desirable and what is acceptable. And this is just putting numbers on things. We want to cool them as aggressively and as fast as possible if we can. Okay, so I don't have ice baths. I don't have cold water dousing. I could, though, if I'm what you call TARP assisted. If you're putting them in a body bag or something similar, and then you put water into that will be quite effective. We don't have that. We have these two, but they seem to be okay effective as well. Like they're at least in the right range here. If you do have ice cold water soaked towels, should be applied in the limbs, including feet and hands and trunk and head, with ice packs placed in the groin, axilla, and neck. Include as much as the body as possible, right? So it's not just in the groin and axilla, it's really everywhere. And then you might also provide whole body wrapped in large sheets, and then have a fan blowing. That's also a solution. Just know that, like, this is not an acceptable level in the guidelines. It has to be this as well. So you might combine these two. And everything below that, water spraying, is different. There's a huge range here as well. So all methods are not good, and just giving them a bit of cold saline is not enough either. It's aggressive cooling, and at our place, this is as aggressive as it gets. Unless it's snowy outside, then we can pull out the snow shovel and get them cool down like that. But and that has been done. But usually marathons don't get hyperthermic, like when they don't have marathons during that season. It's mainly the toxic patients getting in like that. Here's another graph from the Belval. Again, I forgot the V, where they kind of say the same thing. They want to be cooling the patient at 0.15, as we said, per minute. And yeah, the cold shower doesn't really help as much as these TARP assisted, where you submerge the patient. And that's probably one of the take homes. Pre-hospital, they need to be able to submerge patients in water, or a whole body covered, 90% of the body covered in water, and then cooling the water, right? That's the way to do it. Okay, complications. So now we talked about the main, like, heat illness spectrum, as we could call it, and now we'll talk about some of the complications, and I'll just talk about actually two of the complications. I'll talk about the hyponatremia and the rhabdomyolysis, and we'll start off with the rhabdomyolysis. So rhabdomyolysis. Okay, so first, rhabdomyolysis, or a subgroup called exertional rhabdomyolysis, when we're talking about the marathon runner or the athlete who has exertionally acquired rhabdomyolysis. I'll start with the definitions, because it's kind of, there are different definitions of it. And here in Stockholm, rhabdomyolysis is defined as CK, creatinine kinase, of above 80 microcat. And they, for some reason, they don't, as I understand it, use the international units in Stockholm or in Sweden with this. I don't know why, because usually they do. This is, so the normal range is 0 to 15, as I understand it. Or it's also defined as a myoglobin of above 4,000. And this is from the Kunskapsstöd in Stockholm on rhabdomyolysis. If it's a serious one, a serious rhabdomyolysis would be above 300 CK. And then you have this conversion things. Like, so if you want to convert this, then 1 microcat is the same as 60 international units. So 80 microcat would be 4,800 see in international units. So this is interesting when we go down to the Danish and the international definition. And here they would state that, like, the normal range of CK in international units is around 200. And they would say that, like, if it's above 1,000, which is just like above the normal range in the microcats, then that would be pathological, and they would define that as a rhabdomyolysis. Also worth knowing is that CK will increase in the first 2 to 12 hours after injury, and peak within 24 to 74 hours, and decline over 5 to 10 days. So, and myoglobin has a shorter half time and normalizes within a few hours, meaning that might be able to like be used within the first couple of hours before this will peak. But according to Britt Long in his blog about this, he would say that the result is this results in poor sensitivity and thus cannot be relied upon for diagnosis. So in Stockholm, they still do use both myoglobin and CK, but apparently internationally there's skepsis on myoglobin. Here's just a graphic showing that the difference between CK and myoglobin. And this is a problem with just taking one blood sample because it might be rising. So if you take one blood sample and it's below rhabdomyolysis and they don't have any other symptoms, and then it's probably all right. And we'll go into how to assess that. But if they have like a high pre-assessed probability for rhabdomyolysis, meaning that they might have been obtunded before coming in and so on, then probably they need to take several measures, and well, because that goes beyond like a few hours, and they have to be admitted for it. Okay. Here's a rough classification from the IBCC, Josh Farkas. He would say normal CK. That's the same as the Danish definition. Would be this. Mild rhabdo would be this. There's low risk of kidney injury, and that might be like the. It's interesting because the Stockholm definition of rhabdo is beginning here and moderate because the CK would be 5,000 international units. That was the same as 80 microcat. So that's where they draw the line right here, and apparently internationally they will draw it here, and I'll show you the Danish algorithm now as well, because you have to treat this here in Denmark, but you don't have to do it in Sweden in the same. And it seems like it's low risk, so I'm not saying that it's wrong. I'm not saying who's wrong. I'm just saying there's a discrepancy between the guidelines. Okay. So what's the management? Well, if you do have rhabdomyolysis and it's severe enough, and here I would agree with him with the Swedes, because I think aggressive fluid management is not uncomplicated, and it's something that has to be admitted to a higher level of care to actually assess whether the urine output is high enough, and so on. So this is not uncomplicated. It's a potentially harmful management to give this much fluid to anyone. We know that, especially elderly patients, right? So this is not uncomplicated, and I think I have no idea about the literature on this area, but it's probably not unwise to think about whether to aggressively treat mild rhabdo with this. On the other hand, if they do have a high pretest probability, like they have been in a crush injury, or are we going like outside of the topic today? But if they do have a high pretest probability, then yes, then you have to treat it before it rises. It's just like troponin. Like we just don't have an ECG that can show like PCI findings for rhabdomyolysis. We need to, once you have a high pretest probability and you do have a little bump in the CK, then you would expect that it might increase, and then you have to treat it before it increases, but because otherwise it's too late. So that's the problem, and that's why I kind of hate rhabdomyolysis, because it's a really aggressive treatment, and oftentimes people where I work usually take the middle road unless it's very obvious that they have rhabdo. So yes, I guess that's why also a lot of the guidelines are a bit different here, and they don't totally just agree with each other. But what they do say, that if you do have to treat it, whether it's moderate or where you want to draw the line, then you do use isotonic natrium sodium chloride or Ringer's acetate or similar isotonic fluids. If you are a nerd about fluids, then probably not too much sodium chloride to make it pH neutral. And then shift after a while to Ringer's acetate or something similar. The goal is, and this is also different, but depending on the guideline, they would say 250 to 300 milliliters per hour, and then after maybe 12 hours, then you correct the hypovolemia depending on, then you correct depending on what the patient needs. and how it looks and how much it is increasing with the CK. Yeah. And then do these patients need to go in or out? Like they might have a little bump in their creatinine, or they might have a bump in their CK a little bit. Again, getting back to many marathon runners probably have. And what's the baseline here? So this is what Britt Long writes. Despite this, despite the problem that we just talked about with rhabdomyolysis, exertional rhabdomyolysis is usually benign, with most patients recovering with no long-term injuries. And there's different studies on this actually. And a patient with mild symptoms, like with clear etiology, exertional, normal vital signs, normal kidney function and electrolytes, and able to take in oral fluids, may be discharged with follow-up. And patients with an uncertain cause, like they should probably be admitted, right, with renal injury, electrode changes, or prior episodes of rhabdomyolysis, they should be admitted for treatments and then further evaluation. This is American as well, right? It's a bit aggressive, but yes, there are patients that could be sent home. Those with prior episodes can benefit from testing and so on. So yeah. And then he mentions this test here. There are several tools available to help you predict complications and needs for RRT. And one rule from McMahon et al. This is called the McMahon rule or McMahon score. Also in the IBCC references, they call it that. And a score below 5 means that you have a low risk of death, while a score of above 10 has a high risk of death. So any rhabdomyolysis patient, marathon runner with a certain age, that will, and if like a female, 70-year-old female, that might have an initial CK well with 40,000 is high, but but you can see like this is a score. You might add to your blood samples phosphate if you need to. And then you can score this and maybe send them home. That's the hope, at least, right? Here's the Danish one, and sorry it's a little bit small, but it's hard to fit it on one page. If you have like the same thing here, if you have a suspicion of rhabdomyolysis, then you'll start off doing it, giving them fluids, and then you'll get the CK, and if the CK is below 1,000, then it's not rhabdomyolysis. If it's above 1,000, then it is rhabdomyolysis. And then you have to assess the volume status of the patient, and then you continue 30 milliliters per kilo. They do a sepsis like amount of fluid, and so on and so forth. I've never heard the details on this. I've never heard lectures on this. So, but this is a guideline that you could look up. It's the only Scandinavian or at least Swedish and Danish guideline I know of in this area that has been done. So I couldn't find a Swedish one. So yeah, here's the IBCC one for rhabdo. In general, if the CK is under 1,000, then a CK mildly elevated and mechanism of injury places patient at a high risk of rhabdomyolysis, then you should repeat it. But maybe this is the best way of seeing this. Maybe we don't have to repeat this blood sample if you don't have a high risk. So if the patient only have EHE, then maybe we don't have to repeat the tests, right? Even if there's a little bump in CK, then we don't have to repeat it unless other blood samples like suggest that they have EHI, meaning they might have liver damage or kidney damage. Then probably they have to be admitted and checked upon. We don't know, right? But that's the kind of assessment that we have to do, depending on their age and depending on so much other, like how can they be followed up? Do they live far away? So on. Do they have mild rhabdomyolysis? Well, if they do have that, then you could calculate the McMahon score as I just showed you, and then if it's a McMahon, well, they say below 6, and Britt Long would set below 5, but anyway, avoid nephrotoxins, fluid resuscitation, and so on. If concerned, may follow serial lab, but does not like may. That means also may not follow, right? But if the CK is above 5,000, I kind of don't like they always write CK in this like kind of area, but they don't define when the CK is taken. Is it with it is 2 hours, or is it 12 hours, or is it 24? Like, when is the CK taken, right? So it's probably within the 12-hour window that these are taken. That's how I interpret it. Yeah. All right. Then at the end here, EAH, exercise associated hyponatremia. And this is just copy paste from EM cases. Please check the quick hits episode 59, I think it is, out. I got the reference in the beginning of this lecture. And the definition is, well, sodium below 135 after that present within 24 hours from like with physical activity. The primary mechanism is excessive consumption of hypotonic fluid, so they drink a lot of water during their exercise, and then they don't drink enough salts, so that they get an imbalance here, and then they have ADH secretion with EAH, also showed with rhabdomyolysis. So we do also screen them for, when they are in a bad way. And then when they have the electrolyte disturbances, we probably need to take the blood samples. That's what I'm kind of like indirectly getting from all of these things. Studies show that up to 50% of marathon runners have EAH, but not all are symptomatic. So again, here they err on the side of like, okay, 50% of all marathon runners have that, and we do need to think about CK on all of these. Then we probably have to take blood samples on everyone who comes in the emergency department, even though. So we do rely heavily on the triage being done pre-hospitally. Yeah. All right. So there's a range of asymptomatic and critical ill, right, depending on their symptoms. As any other hyponatremic patients, if they're just minorly like bloated and dizzy, but they're not confused, then you'll just will come into the treatment later, but they will be treated with oral hypertonic sodium, because it's an acutely developed, right? We must assume that it's acutely developed, right? If they're healthy, but if they are known with a chronic hyponatremia, then we have to be much more careful if it's an acute on chronic. But usually not a lot of acute on chronic or chronic hyponatremic patients run marathons, but there might be one or two, right? So, but if they are obtunded and they do have a low sodium, then we have to treat them with, treat them like this. So this is also from EM cases, but they probably have it from somewhere else. This is if they are like, if you only have mild symptoms, then you just give them fluid restrictions for like hypotonic fluids, and then you'll give them bouillon or something like that, hyponatremic fluids, hypertonic fluids, so that they will get their sodium up. If they have more severe symptoms, then you'll give them IV boluses of 3% sodium chloride until they're clinically improved. With the caveat of, if they have acute on chronic, then most there's a great lecture on hyponatremia from the Sweets in Sweets 2025 YouTube channel this year, and EM Cases has a great one as well. In general, if you have a hyponatremia patient who is ceasing, then you just give them 3%, and you maximally increase them 6 millimoles, and then you might do a clamp on them. If you're not sure whether they're chronic or acute, if you're sure they're acute, then you can just increase them quite fast beyond the 6 millimoles. But if you're not sure, and you might not always be sure, and then you increase them 4 or 6 millimoles, and then you clamp them so that they don't increase anymore. And because the main problem when it comes to hyponatremia, one of the main things that I didn't realize before I actually started reading up on it is that the ones that do get ODS like osmolytic Pontine syndrome, like demyelinating Pontine syndrome is osmotic demyelinating syndrome. The ones who do get that are the ones that are at high risk, meaning that they have concomitant hypokalemia, which has to be substituted before you touch sodium, because that will also alter the sodium. You also have to like the ones who have liver failure or low albumin in general, the ones who are anorexic, and the ones who have really low sodium, meaning maybe 105, 110. These are the ones. These groups are the highest risk of getting ODS. So these are the ones that you have to be really careful with, and many of them might have acute on chronic when they come in. So here I would be careful, and here I would be. I would increase them only 6 millimoles maybe, and then clamp them. But what I didn't realize was it's not the sodium that we give that is dangerous. It's the problem is if they suddenly they have a high antidiuretic hormone pressure, and then suddenly that releases when you give them the sodium, and then they'll pee a lot, and that's when they hyper concentrate. So if they pee more than 100 milliliters per hour, then you have to be really careful with them. Then you need to they have to have blood samples taken every half an hour, the first couple of hours, until you know whether they are hyperconcentrating. If they're hyperconcentrating, then you need to clamp them with a Minorin DDA VMP, I think they call it, or something like that. DDAMP clamp. Like you have to clamp the urine so that they don't, so that they hyper concentrate their urine and they don't have a lot of free water flowing out. So that they don't hyper concentrate their sodium levels. But this is a low risk here because these patients are not part of that group. So probably we can just ignore that. So who do we admit? Well, I guess all the patients with EHS we admit, obviously. All the patients with EHE who are normal and near normal blood work may have a little bump in the CK, but it's nothing problematic. And they can drink orally and they can pee and they're not obtunded or anything. Then they can probably go home. And then maybe they will have to be followed, maybe not. We don't know. And then ones who have organ damage, have liver damage, they have creatinine bump, maybe they need to be admitted. Shared decision making maybe, depending on their age, depending on a lot of things, depending on follow up. Can they be tested in a couple of days? Depending on the amount of patients that you have, maybe you have you have more than 100 of these patients, and you cannot, like, even though patient volume shouldn't be something that we use it as a requirement for admission, then we all know that sometimes that is a factor, I would say. And then if you have 100 of these patients, low risk patients, you can't admit everyone because there's a crowding problem. Then it'll be a zero-sum game, right? You will have to throw out some of the more critically ill patients, and that's a problem as well. So I don't know with these. I think it will be a case-to-case basis. The elderly ones, the ones that are high creatinine bump, they're the ones that have a high liver bump, they would probably, maybe they have to go in. Yeah, depends. All right, I'll just end this quick and dirty lecture with a case, which is a real case. So this was a patient that we saw who, a young man in his 20s who collapsed at a sport event with 30 or 35 degrees. And the pre-hospital report said that, like, overview, he was collapsed suddenly. I can't remember if he got to the goal or not. Then he ceased, and now he's unconscious when the pre-hospital doctor arrives. He has a nasopharyngeal airway. Sorry, the nasopharyngeal airway. And he's holding his airway with that, without any snoring or anything. He has low vitals, and therefore they put on oxygen 10 liters. They didn't have a saturation at that point. He has warm skin, which is sweaty. Has thin radial pulses, but good carotid and femoral pulses. GCS of 4, glucose of 2.9. Scrapes on knees, but no other injuries. No temperature is measured, is at least not in the report. And they don't say anything about whether they cooled him or not. I'm not saying that they did anything wrong or anything here. They might have just not done the like not written it, but it was not stated that they cooled him. So so this is the patient, right? So a lot of things that actually like looks like he has clinical heat stroke, right? He's obtunded. And also he's a hypoglycemic. He's hypotensive, not much, but some, right? And he doesn't really have trauma. He doesn't have anaphylaxis, what we see. He's not red and swollen, and doesn't have wheezing. He might have cardiac issues, but and you can cease from that. But it's hard to distinguish at this point. But the glucose is an indicator of this not being just that, at least. So during transport, again, they don't state whether he was cool or not, and they don't know the temperature. During transport, he becomes agitated. There's no IV, so he gets intranasal 0.3 milligrams per kilo midazolam, and then he gets an IV, and then he gets another dose. So then he returns to GCS of 4. And then in hospital, when we see him, so we assess him. There's no trauma. We cannot free the neck, of course, but it doesn't seem to have any trauma around that. And I don't think we took him as a trauma. He has a free airway without the the NPA, I should say, not OPA. So now he's holding his airway. He has a respiratory frequency of 40 and SATs of 99 without any oxygen, but he has a low blood pressure and a high pulse. He's agitated now with a GCS of 13 and disoriented. He has a non-focal neurological exam with glucose 2.2. Even though that I think he got glucose in the ambulance, it was not stated, but I think he did get that. So, and the temperature in his ear, again, we only have ear thermometers, was 39. So what do we do here? Well, according to our lecturer, right, we will give him fluids, we'll cool him actually, and we will give him glucose, and probably we will cool him first. And we might give him some benzos to make all of this happen. What we did, we also did POCUS, which showed a collapsed IVC and a hydrodynamic heart. Hard to assess though, because it was also a tachycardic, 180 tachycardia. So this is the ECG, and this is the Swedish way of looking at ECGs. If you want to know more, look at my OMI lecture, or you can look up the Cabrera constellation of doing ECGs. But in short, it is a more logical way of doing it. You just have to get used to it. Where you have the precordial leads here, and you have the other leads here, and it's kind of looking at the heart, so it's more in sync. So you can get to my other videos for the description. But in general, he has a sinus tachycardia. It seems like there are P waves. This is just an average of all of them, and this is the rhythm lead too. He might be a little bit pressed in the ST segment, but not whirling. So I'm not worried about this ECG, other than we need to treat his tachycardia with fluids and cooling him. So the cooling is, and what we did in this particular case, because he was going to be admitted, they did a propofol sedation instead of benzos, because anesthesia was already there. We actively cooled him with cloths in the axilla and groin, and that made his temperature go down quite fast. He got a central temperature monitor, 2 liters of ringers, and then after that he got rhabdo protocol on suspicion of rhabdo, and then he got glucose as well. Right? Lots of things have to happen in a short while here. The blood gas was not taken, was not prioritized at the point because we needed to cool him right away. And so the blood gas I will show you is 45 minutes after. And the blood samples had come at that point, and his creatinine was 200, myoglobin of 4,800. Remember that myoglobin in Sweden above 4,000 is moderate rhabdo, and this is only like right after, so we do suspect that it will increase. And then we also took the TNI here, and that was 326, right? So I don't know what to do with that. He doesn't have any problems. He does have a sinus tachycardia, but he doesn't have a myocardial injury unless he has a pericarditis, which is unlikely, I would say. I would, well, I don't think the perimyocarditis is common enough for us to like if it was not heat related, if it was just collapse related, then maybe, because sports with viral illness can get you a pericarditis, which may or may not turn into myocarditis. I'm not actually sure how rare that is, but I guess theoretically it could. When we're talking about the inflammation here, like the CRP was normal here, so apparently it can be normal. All right, so here was the blood gas, and I do think actually there was a blood gas before this, but it's not recorded in the chart, and it was lost. But I think the lactate there was around 10. Now it's 4 after 2 liters of ringers and extra cooling and glucose and so on. And let's say the glucose is 12. That's good. He has a pH is 7.32, which is not that bad. He's a bit obtunded, 6.0. I mean, it's not that bad either. He has a sodium which is on the higher side. It's but it's not, at least not low. He has a anion gap which is 143 minus 112, which is 31, minus 21, which is around 10, right? And and his normal anion gap would be 10. So he has mainly a NACMA, non-anion gap metabolic acidosis, which is not too surprising with his collapsed IVC. I think he also had some diarrhea, which is also oftentimes seen as vomiting, right? So he has fluid losses. And the blood samples that came back, as I showed you, myoglobin around 4,800. His CK at this point was only 7.7 microcat, which is not enough for him to have a bad rhabdomyolysis, right? So I guess that's why we use this method, taking both of them here. And this was quite recently, right after he came in, right? So we need to retake this. So I'll show you how it went. But he has a creatinine of 188 as well. So we do suspect that he has end organ damage from this heat stroke. Whether it's rhabdomyolysis related or not, he will have to get rhabdomyolysis treatment. And he did get that. All right, so here I have the blood samples, and it's from here to here. This is after 16 hours. We see the let's see. Oh, here we also got the DIC samples, and he has low thrombocytes. What's the D dimer? He has a D dimer that's going up, and he has a fibrinogen that's below 2. So he actually does have some of the features also of APT that's a bit high. So he does actually have features of DIC here. So that's that's part of the part of why we should take these on the really sick patients. His troponin gets a little bit up and then it goes down. It stabilizes. So again, I'm not sure of the value of the troponin here. If you look at his creatinine, then it does fall quite fast. This is a young patient, right? So he does have functioning kidneys initially, at least, but his liver test goes up quite high. But then, yeah. So and then I stopped following this patient after that. But yeah, so it's a good, like, this is a fulminant heat stroke patient, where this aggressive management is so important, right? Let's see his myoglobin. It did fall quite fast as well, as we expect, according to the curve. Let's see the CK. The CK, though, it kept going up, and it became, well, it did go up over the 80, so it was a rhabdomyolysis, but it didn't go over the 300, so it's on the borderline of a severe rhabdomyolysis, this, but not enough. And so it seems like, even though he became a little bit, got a little bit of a dick disseminated intravascular coagulopathy. So this case highlights some of the main features of the heat stroke, where you and we don't. I'm not sure in this case whether he was cooled in the beginning. It doesn't say. I'm sure he was, but this is so important. Like, when he came in, he did have a temperature of 39. Still, right, above 39. Sorry, with a ear thermometer. So essential to cool them aggressively, and then if we can measure rectally their temperature, to know that not all cooling methods are effective enough. So you need to submerge them, or do a tarp, or cover them in a tarp where you submerge them in water or body bag, or the cooling, like, as much as the body has to be covered in cold things, right? All right, so that was the case, and this was my lecture on these heat-associated illnesses. And if you have any comments, if you have any good references or guidelines that I've missed here, then please show them in the comments, because I'm not sure on how to manage a lot of these, like, borderline patients. The most of these patients that do come in, it will be a bit hard for us to actually assess who goes in and who goes out. But it will be an individual assessment from time to time. These ones, as the last case with the heat stroke, they are probably quite clear cut. But yeah, so I thank you for listening, and I hope to see you again another day. Thank you so much.